now talk about, I've been asked to give you a talk on optic disc edema. Now this is a very broad topic, so we're going to quickly narrow down to one kind of disc edema, and that is optic disc edema due to increased intracranial pressure, and that's what we call papilledema. And then we will talk about evaluation and management of papilledema, particularly in the context of idiopathic intracranial hypertension. So just to be clear one more time, what we are talking about now in the next 20 minutes is true, real acquired disc edema, discs that look like this with very thick nerve fiber layer with accompanying pathology like cotton wool spots, hemorrhages, pallor. For this talk, we are not going to do pseudoedema or drusen. That's a whole nother 20-minute talk. Okay, so we're talking about real disc edema. And in my opinion, what I do is I just immediately separate the patients. I separate them into those with unilateral edema and those with bilateral edema. And the reason I do that is it's just easier for me to think about what are the possible causes. Quite honestly, if I see a patient with unilateral disc edema, I'm going to think, ischemia. Maybe this is anterior ischemic optic neuropathy. Or as Arturo showed us, maybe I'm thinking papillitis, demyelination, granuloma, infection. I might consider compression, like a meningioma, maybe even labors, and then the list kind of goes on. Okay, but these are kind of my top 4 for unilateral disc edema. But if the patient has bilateral disc edema, these are all possible to become bilateral, but I'll tell you, I consider something else first. And in bilateral disc edema, I'm first thinking papilledema, increased intracranial pressure, because I have 2 swollen optic discs. The other thing I'll consider is malignant hypertension, accelerated hypertension, infiltration of the nerves by some central nervous system tumor, and maybe even toxicity. But again, I include this list, but it's not maybe first on my consideration. So if I see bilateral disc edema, my first consideration is let's make sure it's not increased intracranial pressure. So to make this easy for me, I came up with my own little checklist of things I need to do on day 1 of the evaluation of the patient with bilateral disc edema. And this is what I do. I go back and I ask the patient about any kind of possible toxicity. Taking amiodarone, took any antibiotics recently, chemotherapy, or were you radiated in the head maybe in the last 6 months? Okay? If I only checked acuity, I make sure on day 1 I get a visual field, I check color vision, and of course the pupil. And on day 1, even though I did a good fundus exam, I want some kind of objective marker of that edema, either OCT, fundus photos, or both. And then I check the blood pressure, okay? And this is why. This is a 37-year-old bus driver who's had headaches for the last few months, and this is not the problem. The problem is he's getting visual blur, and as a professional bus driver, this could be the end of his job if his vision continues to get worse. He's 20/40. He has these paracentral scotomas. He has the bilateral disc edema with hemorrhage and cotton wool spots going into the posterior pole. He says absolutely no medications, no radiation, nothing. He's healthy. Nothing in the last 6 months, so we go to step 4. We check his blood pressure, and it's 240/170. This man does not need an MRI right away. He needs to go to the hospital. So he spent 10 days in the hospital where the blood pressure was slowly reduced, and he came back to 20/20 acuity, and the bilateral disc edema was going away. So this is just a very brief example of malignant hypertension undetected that presented as bilateral swollen optic nerves. So this step is really important. Okay, after I check the blood pressure, now I'm ordering some blood tests. Again, I'm on day 1. I'm going to make sure this patient isn't diabetic, doesn't have severe anemia. I'm looking at renal function. And in the older patient, I always get the sedimentation rate and C-reactive protein, just in case this isn't ischemia from giant cell arteritis. And now, on day one, I have to make a decision. On day one, I have to decide, does this patient need an MRI? Most of the time, yes. And so the big question is when? Do I need that MRI today, Friday at 6 o'clock? Or could it wait till next week? And I think the simple answer is look at your patient. If your patient is holding the head because of a bad headache, okay, or you look at the visual field and there are already visual field defects, yes, I think this patient needs an MRI today, or at least tomorrow, and you should insist. If the patient looks great and is waving at you and you're looking at the visual fields and they're normal, go ahead and order the MRI, but it's okay, in my opinion, to let it wait until next week, okay? What you don't need to do on day one is you don't need to decide right now, this is later, you don't need to decide whether a lumbar puncture is the issue right now. Okay, this is a later decision. So, again, we are talking about papilledema, optic disc edema due to increased intracranial pressure. Now, in the English literature, you will also read increased cerebrospinal fluid, CSF pressure. Also, you may hear the term intracranial hypertension, and I'll tell you these are all equivalent. Okay, they're interchangeable. So let me just remind you a little about cerebrospinal fluid dynamics. Remember, it's made by the choroid plexus deep in the brain. It'll circulate through the lateral ventricles, come down the third ventricle, the aqueduct, into the fourth ventricle, and now that cerebrospinal fluid will pop out this little hole, this foramen of Magendian-Luschka, and now the cerebrospinal fluid is free to circulate all around the brain. The cerebrospinal fluid will circulate down the spinal cord in the subarachnoid space, and the cerebrospinal fluid will circulate along the optic nerve sheath, right? And as it circulates down the optic nerve sheath, it has to come to a stop, and it stops here at the lamina cribosa. Now, the lamina cribosa is a porous, connective tissue that has some flexibility. Remember, it's the part where the optic nerve fibers are exiting the back of the eye. Now, in a very simplistic scheme, you can imagine in front of the lamina cribosa is the pressure of the eye, the intraocular pressure. Behind the lamina cribosa is the other pressure, the intracranial pressure. So in this very simplistic model, okay, if you increase the intraocular pressure, we know that the lamina cribosa deforms, it shifts, it changes a little bit, and this kind of mechanical change can contribute to retinal ganglion cell death. And this is one of the mechanisms proposed in glaucoma. And Francesca, I hope I'm not saying stupid things here. What we do know now in rhesus monkeys is in the back of the lamina cribosa, if you increase the intracranial pressure, okay, well, the lamina cribosa deforms. The blood vessels shift. The pores get smaller, and you squeeze that nerve, and it will finally swell. Now, not everybody reacts in the same way to this high pressure. So some people seem to have a lamina cribosa that's very resilient, very stiff, and won't move much. Other people seem to have a lamina cribosa that's very flexible. And depending, I guess, on what kind you have, maybe how your optic nerve responds to changes in intracranial pressure. So that explains some of the variation that we see in the population. Now, let's stop with the information and let's just look at a case, okay? This is a 42-year-old woman. She's had headaches 6 months, maybe a year. This isn't a problem, but her family doctor said these are not normal optic nerves. And indeed, they are not. But her vision is 20/20, and if you really ask her, she does have tinnitus, pulsatile tinnitus. Her past medical history is significant for hypothyroidism, some renal insufficiency because of a congenital kidney defect, and she takes Synthroid. So let's follow our day one program. We want to ask her about toxins, right? So step one, does she take any kind of other medication? Did she take medication previously? Radiation? No, nothing. Step two, we check the acuity. Now we need the visual field, color, pupil, all of that's normal. Step three, the OCT I show you here. You can see the very high thickness. Step four, blood pressure. Her blood pressure is normal. Step five, let's send some labs. And step six, today we need to decide on an MRI. Does this woman need an MRI? Yes. Does she need it today? I don't think so. And so I felt so comfortable that I ordered her MRI, but it was done 1 week later. And in fact, it was normal. And by that time, all her labs came back normal. So I have bilateral disc edema, normal visual fields, normal acuity, some minor headaches, some ringing in the ears. Are we done? Is this papilledema, and can we just follow the patient? Is that okay? Well, I'm seeing a couple heads saying no. And that's right. This is not a diagnosis yet, and this is not the appropriate treatment. Okay, so the reason being is if you want to call it papilledema, you must show that the pressure is high. And at this time, the most definitive procedure to measure intracranial pressure is still the lumbar puncture. So in adults, the pressure more than 25 is too high. In children, more than 28 is too high. So this woman, we asked her if she would do the lumbar puncture. She said yes, and her pressure is 30. Is that too high? Yes. So now we are clear. She has papilledema, she has intracranial hypertension, or high intracranial pressure. We're very clear. And we already know from her MRI she has no mass lesion. So this is the syndrome of pseudotumor cerebri. Okay? Now remember, pseudotumor cerebri can have some causes. So some of the common causes of pseudotumor cerebri are venous sinus thrombosis, typically cerebral, sometimes jugular. Another association, let's say, with pseudotumor cerebri is sleep apnea. And here we are with the medications that can cause or precipitate increased intracranial pressure. And the things I want you to remember are the antibiotics. Okay? The tetracyclines are used for skin infections. Adolescents and young women use it for acne. Okay, so minocycline. And the fluoroquinolones, we learned about this causing depigmentation of the iris and a reactive pupil. Well, the ciprofloxacin, levofloxacin, moxifloxacin can precipitate increased intracranial pressure. These are very popular antibiotics, so it's very important that you ask. But if you find nothing, then we call this idiopathic pseudotumor cerebri. In the North America and UK regions, they have the term idiopathic intracranial hypertension. Again, these two terms are completely equivalent. Okay? It's your choice. Now, the idiopathic intracranial hypertension profile is very well known. It is a woman, typically, in childbearing age, so let's say 18 to 45, who has recently gained weight or who is frankly obese. This is the typical profile. As Chiara had said, headache is so very common. We know that they have little transient visual blackouts, maybe 1 second, so sometimes they don't tell you. The ringing of the ears and pain in the back and shoulder is common because of stretching of the nerve roots. So how do we evaluate pseudotumor cerebri? Remember, we have those common causes, so we want to make sure it's none of those first. So review that medication list, ask about snoring, and nowadays an MR venogram is recommended for increased intracranial pressure. There are a couple reasons for it. One is simply a few years ago a study came out saying, well, in those patients we thought were idiopathic, in fact 10% had a cause if you really looked for it, and commonly it was venous thrombosis. Another reason that we get the venogram now is because there's increasing use of a venous stent. So we'll talk about that later. All right, so now how do we manage intracranial hypertension? Of course, if you find a cause, you'll treat the cause. But no matter what, the chief morbidity, if you leave the papilledema non-treated, the patient will have visual loss. And so we are eye care specialists. It is our job to prevent visual loss. That is our goal here. So how does visual loss from intracranial hypertension occur? It occurs like glaucoma, okay? So what you get are progressive nerve fiber bundle defects. So what doesn't happen in glaucoma is the first step, the big blind spot. But an early papilledema change is a nasal step, and then an arcuate defect, biarcuate defects, and eventually they coalesce, and then they come down to the center. But again, the papillomacular bundle is the last to go. Now, OCT is so popular now for papilledema, increased intracranial pressure, and that's great, okay? There's no doubt that these standard parameters generally correlate with papilledema grade, but they don't correlate with nerve function. So just as you would not follow glaucoma with OCT only and no visual field, you would not do the same with papilledema. It's OCT and visual field, and increasingly there are customized algorithms for papilledema. The one I like is the one showing this anterior displacement of the Brooks line. This line goes anteriorly because of the deformation of the lamina cribosa from the high pressure behind. Okay, so we said the goal of our treatment is to prevent visual loss, and we have to prevent the visual loss by reducing the pressure and reducing the papilledema. That is our main goal. Secondary goals would be non-visual symptoms like headache. The problem is there is no single best protocol, okay? There is no recipe that works for everybody. So this is how I think many of us do this. First, we classify our patients quickly into those with no visual loss, mild visual loss, moderate to severe visual loss, and then there is rarely this acute fulminant visual loss like every day, going fast, and this is a condition called malignant pseudotumor cerebri. So we're going to start there because it's rare. I just want you to know about it. I've seen 2-3 cases in over 20 years of practice, so it's not common. I just want you to know about it. This is the patient who's losing vision day by day by day, okay, from papilledema. And the goal is simple. You have to drop the pressure now. Okay, not tomorrow, now. And so what we do is all the steps, we do the lumbar puncture, and at the time of lumbar puncture, you can ask them to put in a drain. And this is draining the cerebrospinal fluid at about 15 cc's per hour. At the same time, you put in a couple of IVs, and you're going to add intravenous steroids and intravenous Diamox. We never use steroids for idiopathic intracranial hypertension. Never. But in this scenario, you might, okay? And every day you check the pressure, you look at the vision, you check the fundus, and if there's no improvement, this is a patient that will go to surgery very quickly. And we'll talk about surgery in just a minute. Now, this is the most common scenario that you're going to find. You have your patient with idiopathic intracranial hypertension and papilledema and mild visual loss, and it's been defined as 2 to 7 decibel reduction on the automated perimetry. Okay. This category is the only category where we have class 1 evidence-based medicine to tell us what to do. And this comes from the prospective idiopathic intracranial hypertension treatment trial. And I just summarize it for you quickly. This trial says in this group, you treat them with diet and Diamox. Okay? The diet, how much diet? Well, it's recommended that the patient lose 1% of their body weight per month, and you can target 6% in about 6-7 months. And how much Diamox? Well, start at 500 milligrams once in the morning, once in the afternoon. But you can increase. You can increase to 1 gram 4 times a day. And you monitor them every month. And guess what? The good news is really almost all of them improve their vision, improve the visual field, and most of them will normalize their visual field defect. So this is a regimen that works for this group, and usually everybody is happy, usually. Now, what if you have the patient with papilledema, intracranial hypertension, but there's really no visual loss? Less than 2 decibels of reduction, the visual field looks like this. What do you do? Again, now we don't have any evidence-based medicine, so what I do is I use the same treatment. I use diet and Diamox, but I'm a little bit more relaxed. Maybe I don't use quite so much Diamox. I try more natural therapy with the weight loss. I know it takes a little time, okay? Or maybe I might even use Topamax, which is kind of a cousin of Diamox, but Topamax is good for headache. But I feel like I have a little margin to play with this. So here's our patient, do you remember? Okay, she had the pressure of 30, so she has no secondary cause, so she has idiopathic intracranial hypertension, and we proposed to her, she has the no visual loss, diet and Diamox. But her kidney doctor said, stop, no Diamox, because she has a little kidney dysfunction. Okay, this is fine. We treated her with weight loss only. So here as she is before. This is not her. Of course, I didn't take a picture of her without her clothes on, but I got this from the internet. But she has this kind of weight mostly around the hips, okay? And 8 months later, she dropped from 85 kilos to 73 kilos, and look at her optic discs, okay? So it's a very successful treatment. We took the time. She didn't have visual loss, so we felt comfortable to use this kind of slow, natural treatment. And the bottom line is that weight loss works for increased intracranial pressure. Now, the story is different. If the patient already on day 1 has some visual loss, you can see it here. I'm already worried, okay, and I'm a little anxious. I'm going to start that diet and Diamox, okay? But at any sign of progression, I'm kind of moving to surgery. Okay, so this kind of patient, I'm being a little bit anxious and ready to go to surgery. So the question is, what surgery? Pretty much you have 2 options at this time. One, you can put a fenestration, a window or a hole in the sheath, and now you let all that fluid drain into the orbit. None of it will touch the lamina cribosa. Another option is you can put a tube in the back and drain all that fluid into the abdomen. Or you can put the tube in the head, and again, all the fluid drains into the abdomen. In both, you're just draining the CSF someplace else. Get it off the lamina cribosa. Which one works? Well, we don't know which one is better. We don't have any randomized control studies at this time comparing the 2, but we know from clinical practice and case reports and series that in the short term, they both work. They both reduce papilledema very quickly, and they both stabilize vision very quickly. So my advice to you is find out which procedure is more popular at your own institute, and that's the one that you would recommend. Okay? All right, now, on the horizon, coming up or close to being ready for use are new treatments for intracranial hypertension, and probably the one coming in now is bariatric surgery, because we know weight loss works. Okay? So for those who have a body mass index greater than 35, bariatric surgery can be recommended as a first option. They lose the weight quickly and they keep the weight off. And there's actually a trial looking at weight loss from surgery versus looking at weight loss from Weight Watchers, which is a more prolonged process. Remember I told you to get the MR venogram in patients with pseudotumor cerebri. It's because some of them have this cerebral venous sinus stenosis, maybe not obstruction or thrombosis, but a stenosis. And if you can show that they have a pressure gradient, a stent is very effective in reducing the pressure. Okay? And then there's a new medication out called 11-beta hydroxysteroid dehydrogenase 1 inhibitor. And I hope they come with a shorter name. But this is a medication that was started to treat obesity. It is an enzyme that converts inactive cortisol to cortisone in the cell. So if you can stop that, these cells don't use as much of the cortisol. It reduces obesity and it reduces diabetes. So it was started for that reason. But this cell also reduces aqueous production, and this enzyme also, and this medication also reduces cerebrospinal fluid production. So this is a medication currently out to see if it might help intracranial pressure. So quickly, let's summarize the management, okay? First, look for and treat underlying cause, like look for apnea medications, get the venogram. Secondly, for patients with no visual loss, mild visual loss, kind of early moderate visual loss, I think this whole group of patients can start with diet and Diamox, and you see how they do. If all goes well, the papilledema is gone in 6 to 9 months. There's no visual progression, and now you can start to slowly decrease the Diamox, and the patient should maintain their weight loss, okay? At any point, if you see progressive visual loss or papilledema that just really won't go away despite medical treatment, then these are the patients that you're going to consider to move on to surgical intervention. And now, again, for those in whom you find venous stenosis, stenting is an option. And yes, I'm going to stop here, and thank you for your attention.